My name is Sarah McKay, and I'm a current student researcher at the Foundation for Surgical Innovation in Education. I would like to thank SAGES for giving me the opportunity to present our research on the long-term clinical outcomes of 100 patients following POEM. Per-oral endoscopic myotomy is an endoscopic approach to myotomy across the GE junction for treatment of achalasia and other esophageal motility disorders. Alternative treatment options include laparoscopic myotomy and pneumatic dilation. There have been well-documented short-term success rates following POEM. In 2015, we published the results of our first 100 procedures with an 83% success rate and a mean follow-up time of 22 months. There was a slight decrement in outcomes of the patients who were followed longer term. The aim of the study was to investigate the long-term clinical outcomes of POEM in a large cohort where all patients had at least 5 years of follow-up. The study consisted of a retrospective review of 138 patients who underwent POEM at the Oregon Clinic between October 2010 and September 2014. Patients were contacted by a single investigator for phone interview. Patients were excluded if they were unable to complete the long-term, greater than 5-year post-op symptom questionnaire. Patients were considered clinical success if they were free from reintervention and their accurate score was less than 3 at long-term. Patients were worked up preoperatively and evaluated using the accurate score, which grades symptoms on a scale of 0 to 12, with higher numbers correlating to more severe or frequent symptoms. In order to achieve clinical success as an accurate score less than 3, patients could have no more than 1 symptom daily or 2 symptoms on occasion. Patients were classified as type 1, 2, or 3 achalasia, or DES, as defined by the Chicago classification. Manometry was re-reviewed by the senior authors to ensure that patients were classified by the most recent up-to-date Chicago classification. Patients who underwent surgery for manometric EGJ outflow obstruction were labeled type 4 achalasia. This emphasized the difference between manometric EGJ outflow obstruction that has multiple etiologies and the clinical entity of achalasia symptoms in the absence of other causes. Type 4 achalasia was defined as EGJ outflow obstruction with an elevated IRP and disordered peristalsis not meeting criteria for types 1 through 3 achalasia, but presenting with clinical symptoms suggestive of classic achalasia in the absence of other causes of EGJ outflow obstruction. Importantly, these patients were not the same as EGJ outflow obstruction, and they all underwent preoperative evaluation to ensure abnormal acid exposure, and hiatal hernia were ruled out. Cross-sectional imaging was also obtained selectively. Our cohort consists of 138 patients, 38 of which were lost to follow-up, leaving us with a 73% follow-up rate. 100 were included. 94 patients of those 100 were classified as achalasia types 1 through 4, and 6 of the 100 patients were classified as DES. Preoperatively, the demographics were as follows. Average age was 57. Average BMI was 27. There were 52 males and 48 females. 23 patients underwent pre-POEM endoscopic interventions. 2 patients underwent prior dilations, and 21 patients underwent Botox injections. 6 patients also underwent laparoscopic myotomy prior to their POEM. Our symptomatic outcomes were obtained at a median of 72 months, with the longest patient being followed up at 106 months post-POEM. In our achalasia cohorts, the pre-op mean accurate score was 6.2, decreased to 1.4 at 6 months post-operatively, and sustained at 1.8 at long-term follow-up. In our DES cohort, their preoperative mean accurate score was 8, decreased to 3.2 at 6 months postoperatively, and again decreased to 2.2 at greater than 5 years follow-up. The achalasia cohort had an overall success rate of 80%, again as defined by accurate score less than 3 and free from reintervention. In our DES cohort, we report a 67% overall success rate. These graphs present our data for all 100 patients classified by their subtypes, and we found that the achalasia subtypes had greater improvement in their Eckert score than the DES cohort. 7% of our patients underwent reintervention during their postoperative course. One patient underwent 35 millimeter balloon dilation, 2 underwent redo POEM, and 4 underwent laparoscopic Heller myotomy with partial fundoplication. Of our entire cohort, 79 patients achieved clinical success. 21 were clinical failures. Of those 21 clinical failures, 14 were classified as Eckert score failures. Eckert score less or greater than 3 was seen in 10 of those patients, and Eckert score equal to 3 was seen in 4 of those patients. Of the 21 clinical failures, there were 5 who underwent reintervention, and there were 2 patients who were Eckert score failures despite reintervention. A large majority of our patients report clinical success without significant decrement in postoperative Eckert scores. 91% of our patients report improvement in their dysphagia. And when asked about their satisfaction with POEM, 93% reported complete satisfaction with POEM. POEM is an effective option with excellent long-term durability and should be considered first-line therapy for achalasia. Thank you.